All right, and move on to introductions of our people. As I said, the session will be recorded. There is the link right there. Mute your mic. We will have opportunities for questions during the presentations, and we'll allow them after each segment of the webinar and at the end. We will be asking for feedback and questions or suggestions for future learning, and I'll send that out after the webinar. Our next webinar is slated for June 6, 2019. The topic is Low German speaking Mennonites in Southern Alberta. Our presenters, Dr. Eric Bly is a family physician in Lethbridge, Alberta, with an interest in newcomer health. He is a founding member of our group and has worked extensively with members of the Nepali-speaking community. Bojana Slajuka is manager of settlement programs with Lethbridge Family Services and Immigrant Services Programming. Bojana oversees resettlement assistance programming specifically for government-assisted refugees and settlement program for all other newcomers who settle in Lethbridge and area. Jolynn Ashtai is one of 3 managers for public health nursing in South Zone. She is based in Lethbridge and holds South Zone Public Health Program responsibility for communicable disease control, TB, and newcomer health, sexual and reproductive health, and better beginnings. Lindsay Schwab is a registered dietitian and certified diabetes educator for Alberta Health Services with the Alberta Healthy Living Program in Lethbridge. She works with adults and children with type 1 and type 2 diabetes, teaches various nutrition classes, and attends newcomer multidisciplinary clinics. Tennille Entz is the tuberculosis coordinator for South Zone Alberta under the division of the Alberta Health Services. She has an interest in newcomer health and was involved with the development of the multidisciplinary clinics, as well as the testing for TB photonovella. And last but not least, Laura Branner is the Lethbridge Local Community Partnership, LIP, coordinator, or Lethbridge, Immigrant Partnership. Laura also worked as an English as a second language educator. So we'll start with the presentation. I'm going to mute, and Dr. Bly, you can start us off.
Okay, can everybody hear me? Yes? Okay. So when a newcomer first comes to your office, one of the first things to remember is that you will need to plan extra time. There are a lot of factors involved. Each step along the way is probably going to take a little bit of extra time, and that adds up. So don't just plan a brief short visit. You won't get through much. Remember that for them this is one more step in a long journey, even though to you it might be your first encounter with them. They may have already seen many other healthcare practitioners or officials and everything in their so be patient and consider their journey and what they've been through already. Do your homework, figure out what country they're coming from, and then even before that, sometimes they go through multiple countries before they get to you. Find out what languages they speak, find out how good their English is. Look into cultural norms or practices that might affect your visit ahead of time. You'll need to arrange for an interpreter. Now, really quick, the difference between a translator and an interpreter will interpret the spoken word, whereas a translator deals with printed material. You need to know how to use an interpreter. So we'll probably go over this again, but things like using easy to understand language, avoid jargon, avoid complicated phrases or idioms. When you're using an interpreter, you place the interpreter off to the side a little bit where you can see them, but you are face to face with the patient, and you speak as if you are speaking with the patient. You say what you're going to say, the interpreter will translate it. The patient will say what they need to say, the interpreter will translate it. Don't speak directly to the interpreter. You are speaking with the patient, and the interpreter is just there to make your words known. Find out what screening work has already been done. Sometimes that's very little. Find out what else needs to be done. The Center for Disease Control has a lot of good information on their websites. For example, they have something called a summary checklist for the domestic medical examination for newly arriving refugees. You can look at what area they're coming from and find out what conditions might come within those populations, and you may need to screen for those. The CFPC also has some resources on refugee healthcare. They have a section called Resources to Assist Family Physicians. And when in doubt, check with your local Office of Public Health. They will have an understanding of what their requirements are for knowing that vaccines and screening tests have taken place, and they can certainly customize your screening needs based on local needs. Don't assume that regular screening has been done. Many things that we take for granted just do not get done in other places. For example, pap testing, that a lot of places just don't do that, or if it's available, it's not available to people in refugee camps, things like that. So don't assume anything's been done. Before the visit, find out how many people are coming. Sometimes you may think you're only seeing the parents, but you might have the entire family, you might have extended family. Try and get a sense of how many people are going to be there, and if you can't accommodate that number, you'll need to make that known before they show up for the visit. Otherwise, you need to look at how to accommodate the number of people that are going to be there. Find out how much education you can expect them to have. That's not always easy, but it can make the difference in how you talk to them. Try and find out what they may have been through already. When did this experience start? When did they start on their journey to get to where they are now? Have they been through abuse, torture, war, death of loved ones? They may be suffering from PTSD. Those are all things that you need to be aware of before they enter your office. Think about cultural sensitivity. This could be religion. This could be their beliefs on male-female relationships. A female patient and a male doctor may not be a good fit for some cultures. See if you have an idea of what ideas and beliefs they may have around medical practices ahead of time. But don't assume that everybody from that group is going to have the same either religion or beliefs. So ask. But sometimes having an idea of what sorts of things, find out what sorts of things you might have to deal with ahead of time so that you can anticipate potential problems.
I'm just going to interrupt you just for a moment, Dr. Bly. Sorry. The folks who are on the phone, please be sure to mute your lines. We can hear some breathing, and this is being recorded, so we want a clear recording. Thank you.
There may be other referrals required, such as to public health for tuberculosis screening or treatment. They often will need optometry or dental work done, and we'll have a little bit more on that later. One other thing to...
Please mute. Please, those of you who are on the telephone lines, mute your lines. Somebody's breathing really loudly.
So bottom line, know what you're getting into, plan extra time, see what you can find out about them ahead of time that may help you streamline your visit with them and make sure you've covered anything that you need. So that's it for my presentation. Do we open it up for questions now? Is that the plan?
Yeah, we certainly do.
Okay.
I will mute those. Thank you, Mohammed, for reminding me of that. Are there any questions for Dr. Bly? Dr. Bly was one of the physicians who saw a lot of our Bhutanese refugees in Lethbridge, and as we said, was involved right from the get-go.
Quiet bunch.
Very quiet.
Or have you muted them all?
Nope. I'm not muted anybody.
Okay.
Everybody,
Dr. Bly, I have a quick question. It's
Sure.
Shannon Spenceley here on the line, and I had to go to answer my door. So if you said this and I missed it, I apologize in advance.
Okay.
I think you've really set up well sort of how the primary care provider can be prepared for what sort of could be happening and how to set up that interaction so that it goes well. Is there anything in terms of the setup of the office or the preparation of staff who will be greeting people from other cultures? Is there anything there that it would be good learning to make? Sometimes doctors' offices in these places can be really intimidating for folks, and I wondered if that was part of your considerations at all.
Yeah, that is true. It can be very intimidating to people, and probably the biggest things are staff, making sure your staff are trained in cultural sensitivity. If somebody doesn't understand them, that doesn't mean they should speak louder. They need to understand, when they call somebody's name, they may not understand your pronunciation of their name. So familiarizing themselves with the interpreters ahead of time is helpful. And as far as setup for the office, mostly having enough space. Sometimes if you've got an extended family in a small room, it gets very tight. So if you know you have an entire family coming in, you might want to look at using a bigger room. Just making sure that your staff are friendly and welcoming and realize that these people are likely to need extra help to navigate what we take for granted as being a very straightforward situation. To them, it is often completely foreign.
Right. That's really helpful. Thank you.
This is Manoj. Dr. Bly, I have a question. Have you encountered in your situation when you looked into the cross-cultural and across the board when newcomers come in with the diagnosis as to how they accept, understand the terms that we use? Because I saw in some situations, even as a nurse as well as an interpreter, that in situations when they hear some of the diagnosis, they hear, say for that instance, cancer, and then they understand that as a death warrant, be it a cancer on the first stage or the third stage or however progressed it might be, right? So how do you actually, and some of the population are illiterate even in their own languages. So in that situation, how do you what are the types of strategies that you have adopted that has helped this type of population group to understand where they stand in terms of their disease process, what to anticipate from the plan?
Good question, Manoj. Thanks. So we did have, for example, that situation where we had a lady who had never had pap testing, and so we did a pap on her, and she had cervical cancer. And as soon as she heard the word cervical cancer, she thought her life was over. And so we sent her for a hysterectomy. It went fine. There was the chances of the cancer spreading were very minimal, but every visit she came in, she assumed that she was dying, and I didn't know that ahead of time, so it took me months before somebody explained it to me that the reason she kept coming back again and again is she was sure that she was going to die, and every symptom that she had she attributed to cancer. So the best thing is probably, again, that cultural sensitivity, finding out what you can ahead of time, talking to people from that community, talking with the interpreters, sometimes before and after the visits, so debriefing with the interpreter after. They may be able to point out things to you that you were not aware of, that they would not be comfortable discussing in front of the patient, like cultural beliefs and practices. And then often asking them, it's your usual feelings, ideas, function, expectations. So asking them what they understand about their condition and what they expect, what their expectations are for recovery, things like that. Don't take anything for granted, especially places that have very little access to healthcare. Their exposure may be very minimal, and they might be relying on anecdotal stories or folk medicine or just beliefs that have passed through the group that we may not be aware of. Good question, Moj. Thanks.
Thank you. I have another question too, though. I'm sorry, too many.
Go ahead.
The second question is with regard to family as an interpreter. How do you take it and how do you accommodate that if that is what you feel comfortable with? And how do you make sure that the family can sometimes be used as an interpreter when the other interpreters might not be accessible? And what is the age group that you look into and things of that nature, and how do you address that sensitively so that the client is benefited from the interpretation but not taken advantage of in the family sometimes of their own vulnerability?
Right. So there are a number of factors that play into this. For starters, we try to get an interpreter who's not a family member as much as possible so that we can avoid that. But like you said, sometimes it's unavoidable. Although if you have access to the language line, if you think you might be discussing things of a sensitive nature, such as sexuality or possibly abuse or depression, anxiety, interpersonal family relations, you may not want the 7-year-old son to be your interpreter. So if you know that could be an issue, then there's definitely the language line. Otherwise, if that's all you've got, then the older the better. I have had to use 10-year-olds as interpreters before. It's not ideal, but sometimes that's all we've got. And you will have to coach them on how interpreting works because they've never been an actual interpreter, so they may be going on a long rambling conversation with you or their family member and not realizing that they're not translating everything. So again, ideally try not to use family members. In cases where people require counseling, we often will just tell them we can't have a family member interpreting because it interferes with the counseling process sometimes. And then otherwise, if the language line, if you've got it for that language and if you have access to that, and then otherwise use the oldest, most responsible family member you can get a hold of.
Thank you.
Great.
You're welcome.
Thanks, Dr. Bly. So we'll move along on the presentation. You'll have an opportunity to ask questions later. So if there's anything that you want to ask Dr. Bly, hold that until later in the webinar. Our next speaker is Bojana Slejuka. She is the Manager of Settlement Services, and she's going to be talking to us about making referrals for newcomers. Bojana.
Hello, can everybody hear me?
Yeah.
All good? Okay.
Yeah.
So what I'm going to talk about is a referral process to the multidisciplinary clinic and LFS role in that process. So in 2016, in order to respond to influx of the Syrian refugees, Alberta Health Services and through Public Health and LFS, we created a new way of assessing refugee health needs by organizing monthly primary and secondary multidisciplinary clinics that brings together various health disciplines. And I'll leave with Jolene to explain later on a little bit more what those health disciplines are. Once refugees arrive to Lethbridge, they are assigned a family doctor through the Chinook Primary Care Network, and at the same time, referral is made to the public health to attend multidisciplinary clinics. So all refugees who arrive either as government-assisted refugees, privately sponsored refugees, and protected person, as well as those who move from other parts of Canada, go through the same process. Upon arrival, we do send referral information with the basic demographics of the refugee clients, and that includes family composition, country of birth, as well as country where they have been refugees. Also, we do provide Alberta healthcare number and as well assigned family doctor for the further communication. Also, we attach the copies of the immunization records that clients are actually now receiving during their immigration medical, or if they have immunization records from their own country. We do include some of the additional medical information in order for the clinics to be set up, such as pregnancy, smoking, if there's diabetes, mental health needs, and in some situation, if a patient had history of cancer, so that health nurses are able to assess suitability for client to get immunization and other supports. So once public health organizing all the appointments and schedules, LFS provides interpreters for that day that both primary and secondary clinics are set up. For the further appointments, public health uses a language line, and we organize transportation to the public health, and we ensure that clients do attend these appointments. We do assign settlement practitioner to stay throughout the multidisciplinary clinics so that they can receive the copies of the assessment sheets and then further do the follow-up with the doctors and other medical appointments. So I think that's from our side.
All right. Moving on to you, Jolynn. Jolynn is the manager of public health nursing and will be speaking to us about multidisciplinary clinics.
Okay, thanks. So just like Bojana said, we had a need to look at a different process for how we, in public health and in healthcare just in general, responded to this huge influx of a new group coming in a very short time frame. And so we came up with this idea of the multidisciplinary clinic. Our sort of intent was to look at an ability to see a lot of people all in a short time frame, but also to be able to have kind of a one-stop shop sort of scenario where we could have it just made it easier for those clients themselves to not have multiple appointments in multiple different places. So we brought many different healthcare services agencies together in one sort of space. We had, and this was in response to the Syrian refugees coming in, but we were also still seeing other refugees, other immigrants coming in. So we needed to be able to adapt to these different numbers. So we did plan for primary and secondary clinics. We ended up doing our clinics at Lethbridge Family Services, Immigrant Services, which really worked. I mean, it was a smaller space, it was a bit crowded, but the bonus was it was a familiar place for the clients coming in. They'd already been there, they'd already connected with LFS, Lethbridge Family Services staff, so it was kind of a good place to start off from. We did know that there were a few that had kind of urgent medical needs, so we wanted to make sure some of that was covered as well. So we ended up with public health nursing, oral health, so our oral health public health program was there. They actually provided quite a lot of service direct in the clinics, not just the assessments, but fluoride varnishes and things like that. Alberta Healthy Living, chronic disease, had a representation there, still does. Addiction and mental health, smoking cessation. We had our Better Beginnings program. So for those who are familiar with the Canadian Prenatal Nutrition Program, that's our funded program here. So for women who were pregnant or maybe had just had a baby. We had physicians there as well, and we had the lab. We also had some volunteers from Alberta Health Services that helped with kind of navigating from one station to another through those original multidisciplinary clinics. And generally, we had, like I said, we had the primary clinic and the secondary clinic. Those were booked 4 weeks apart, but we had clinics every 2 weeks just because of the numbers that were coming in all at the same time. So most clients in those first months were seen within about a 2 to 3 week time of arrival. we had families, it depended on where they were coming from, but family sizes ranged, but most were kind of the 5 to 10 plus. Some of them even were bigger than 10 members in a family, but that 5 to 10 was kind of the average range of the family sizes that were coming. As Bojana mentioned too, we had both privately sponsored and government assisted coming in. That's kind of the sort of historical, I guess, start of the multidisciplinary clinics. Where we've gone to now, because we're not as much in a responsive sort of need, it's kind of moved into current sort of flow, current practice. We have still primary and secondary clinics running, but we have them just once a month. So this has allowed us a little bit more time to plan and be able to organize clinics a little bit better. It also has allowed us to be able to get all of those records that Bojana mentioned, to be able to have those records translated, to have clients, everybody has their Alberta Healthcare assigned, clients are registered in our systems so that everything can be done a little bit better in the actual clinic. So documentation can be happening easier and faster. There's not a backlog at the registration table like there was in those first initial clinics when some of the paperwork sort of stuff wasn't able to be done ahead of the clinics. So that's kind of where we're at. The one other difference, I guess, is we have changed a little bit of who the participants are in the way of services. We no longer have lab and physician available. People tend to now be established here a little bit longer before they come to our multidisciplinary clinics, so they often have seen a physician prior to, or may have seen a physician prior to. And then the other one that we don't have coming regularly anymore is addiction and mental health. We still do sort of have screening for that, and we can refer to addiction and mental health if needed, but they're no longer participating in the actual multidisciplinary clinics. And that's my part.
Great. Thanks, Jolynn. Lindsay Schwab is a dietitian with the Alberta Healthy Living Program. The program was also involved in the multidisciplinary clinics. Lindsay, what do you have to add about the experience?
Can I just ask one question first? Maybe I missed this, but what is the difference between a primary and secondary clinic?
So the primary clinic was the first one. It's just 2 clinics. It was just, sorry, Ryan, I should have said that. Thank you for asking. It was just an ability for us to, from public health's perspective specifically, they would come in and they would get their initial immunizations, and then they need second doses. Most times people needed second doses in about 4 weeks or about a month later sort of thing. And so because we're dealing with such high numbers, rather than transitioning them into our regular clinic flow for the second doses, because we're still dealing with so many at the same time, it just made more sense to continue with a secondary clinic to be able to see those en masse, to get those immunizations done in the second multidisciplinary clinic, so a secondary clinic, and then we transition them into our regular clinics. Because if anybody needs more than those 2 appointments, it's generally not all of the family members that would need further follow-up.
Wonderful. Thanks, Jolynn.
You bet.
Yeah, we found the primary clinic, often families were this is Lindsay speaking, often very overwhelmed, especially in the very beginning when we were seeing them really soon after they came to Canada. And so a chronic disease screening was often very overwhelming for them. So sometimes we would just defer that to the secondary clinic if they had been through a lot already that day. But yeah, I don't have a lot to add. You really described it well, Jolynn.
Great. Thanks, ladies. Tennille is the team lead for TB services and very experienced, and she and Dr. Bly are going to talk to us a little bit about managing, TB risk.
Perfect. Thanks for the invite to attend and present to this, everybody. So I will start off from the public health side of this, and then Dr. Bly will address more of the medical physician side of this. Hopefully my voice holds out. Everybody can hear me, I presume?
Yep.
Yes.
Okay, so just a brief summary of TB. I guess I could also say TB 101. Often tuberculosis is not well understood. Tuberculosis can be categorized as an infection or a disease. TB infection is where the host is infected with mycobacterium bacteria, but it's sleeping or also referred to as latent. This infection has the ability to remain dormant or sleeping for a lifetime in somebody or wake up and cause illness, which is definitely more with an individual that has a medical risk factor that causes immunosuppression. A healthy individual with latent TB has less than a 10% chance that TB will convert to active TB as long as they stay healthy. Tuberculosis disease, on the other hand, is when TB bacteria is active and replicating within the host. Active TB causes damage to the tissues and the organs and is often infectious and may be spread to others. The fatality rate really of pulmonary TB is 50% if it's not treated adequately. So I guess the question, my topic today is how do we manage this TB risk in our zone? So public health nursing is actually responsible for the screening and the follow-up of community tuberculosis under the direct supervision and direction of Central TB Services within Alberta Health Services, and that's who I work for. New arrivals to Canada with refugee status qualify for this TB screening if they were born in a TB endemic country, and that is guided by the Global Tuberculosis Report 2015. So the definition of an endemic country is 30 cases per 100,000 people. So we make that a little more in context. If we were looking at Lethbridge, if we had 30 active cases in Lethbridge, we'd be considered an endemic country. The other people that actually qualify for tuberculosis screening from an endemic country, if they're not refugees, are children under the age of 14 years old coming from an endemic country. So these are people that can just be referred or self-refer them and their families to be screened by the public health nursing. So most of our eligible immigrants and refugees are referred to us in public health by the Lethbridge Family Services, Bojana and her team there. These families are assessed in the multidisciplinary clinic, as Jolyn had described, and they're screened for tuberculosis if they were from an endemic country. And as needed, their testing and their treatment is arranged by public health nursing with support and partnerships with their local family physicians. Latent TB or sleeping TB treatment, if it's deemed to be necessary, is a treatment regime actually of 4 to 9 months with monthly visits to see a public health nurse specialized in TB for assessment, screening, and medication renewal. Active TB treatment, contrary to that, is mandatory by law, the Public Health Act, just for the protection of others. And each antibiotic dose has to be observed by a public health registered nurse, and active TB treatment regimes can range from anywhere from 6 to 24 months in duration. And that can actually even end up being longer if it's a multi-drug resistant TB. So contact tracing is done by our office here and myself, and all active cases that have pulmonary TB or laryngeal TB that is infectious has to be done, and that is all directed by Central TB Services. Language line is what the nurses are all trained and expected to use here in all the clinic visits. So all of this, all of the care we're giving and the treatment and the follow-up is understood by the patient themselves. And I completely agree with Dr. Bly. We find it very risky to use a family member. We don't know, we can't understand what the family member is translating for us, and it becomes a little bit of a shift of power when you're letting a child translate for their parent. It shifts the power in the home as well. Our nurses here in the health office are all aware that that is not accepted practice unless absolutely there really is no other option. So prior to arrival in Canada, the other way that we see people is the pre-travel immigration screening that can identify individuals' risk factors. So prior to travel, they'll have an X-ray and some other screening done, and if these X-rays look abnormal, if we've identified or the immigration team has identified that they've had previous active disease of TB or treatment or TB exposure, travelers are actually flagged and assigned an Immigration, Refugee, and Citizenship Canada letter. This letter outlines the expectation of their medical surveillance undertaking. The letters are actually called medical surveillance letters. And these people are required, that have been deemed to be at potential risk, are required to report to our public health office, our RNs here at the health office, and testing, it has to be done within an allotted time frame. That's 30 days for somebody low risk, 7 days for someone that's deemed high risk. Public health nursing arranges all this testing, and once these results are complete, a referral is processed and a medical direction is provided by our TB physician through Central TB Services. And again, the same process as if they were an immigrant or refugee. They would most often be have further testing, yearly surveillance, or treatment if deemed necessary. And that's it from the public health end. Is there any questions?
Hi, Tennille. This is Jennifer. I have
Hi,
a question
Jennifer.
for you with regards to physicians. So the challenge that we face here is say your refugees that you have coming in, is that the delay to get them started on latent tuberculosis is because they don't have a family physician. Mm-hmm. So do you find with this newcomer and these clinics that you run once a month, is that there's a physician that will take them on, and therefore...
Yeah, and to sign off on their treatment. Yeah, it's a really good question, Jennifer, because we used to, about 5 years ago, have a big problem with this. It was very difficult in Lethbridge to find a family physician that was taking new patients. The multidisciplinary clinic, one of the process in developing the multidisciplinary clinic was actually connecting with the primary care office team, the physicians, and we had a group of physicians. I think Dr. Bly can correct me, but I think it was about 12 or 13 physicians that agreed to take on all of these new arrivals coming in. So they were connected with a physician before they even arrived, and that relationship was built. At this point now, again, Dr. Bly can talk a little bit better on this, but I know that we have a ton of physicians in Lethbridge at this current state taking new patients. So no, at this point we don't have any problems with this, and we still, even though the multidisciplinary clinic has been adapted for the need, we still do have the primary care network connecting the refugees with physicians upon arrival.
Perfect. Thank you.
So, Dr. Bly here. Right now in Lethbridge, we have multiple family physicians taking patients, so nobody should, if somebody's telling you they can't get a family physician, then they're having trouble navigating the system, because we have, I'm sure we have 8 or 10 physicians right now taking new patients, so that shouldn't be an issue. Now, Tennille, correct me if I'm wrong, but you don't have to have a physician in order to get started on treatment. Is that correct?
You know what, Dr. Bly, at this point, we do expect that back. Okay. 5, 6, 7 years ago, actually, we had the RN sign off because we literally could not find physicians for people. But at this point, we do expect every person does connect with a physician.
Okay. So I have a few things to say about active TB in the office, or so one of the first things is have a low threshold of suspicion when you have somebody from an endemic area. My example was we had this elderly gentleman who had a cough, kind of your usual cough, like a cough and cold, for a little while. We thought possibly he had some pneumonia. We put him on your typical community-acquired pneumonia antibiotic. He didn't get better. I did an X-ray, and it was just the whole side of his lung was just filled with TB. So have a low threshold of suspicion and look for it. One of the good things about TB is it's actually quite difficult to catch. You cannot catch TB with casual exposure. So Tennille can correct me if I'm wrong, but my understanding is you need 4 hours cumulative of close contact, which would be in the same room as someone with active TB in order for you to be at risk of acquiring it, and 8 hours of intermittent cumulative contact with somebody in order to be at risk. And if you meet those criteria, then you get started on prophylactic treatment. But 4 hours in a doctor's office is a long time, so that's not something we usually run into that sort of exposure. Another thing to remember is if you suspect TB, try and isolate them as much as you can. Nobody expects us to have negative pressure rooms like they do in the big hospitals, but maybe find somewhere that's not in the waiting room. And even though I just said that it takes a lot of contact, a lot of close exposure in order to be at risk, you still don't want somebody with TB coughing in your waiting room for a variety of reasons. That's pretty much all I had to say about TB. Now, when you were talking about interpreters and family members, I did have an interesting story where we had a 10-year-old boy interpreting for his mother. And just to show you some of the problems that can happen with family members interpreting, Mom insisted that he was a vegetarian, and he told us how much he loved hamburgers. So he obviously was not telling Mom everything he was telling us. So, yep, that's about it. Any questions from either of us?
This is Manoj. I have a question. I'm sorry. Regarding the strains of TB and the types of the categories of the TB that Tennille was talking about before, the active TB, latent TB, and I had attended one of the Beyond Borders, the Doctors Beyond Borders seminar, and then they had talked about a resistant TB as well. Could you shed some light on that?
Tennille, I'll leave this to you.
Sorry, just Manoj, I heard that you said latent TB and active TB, but what was the third?
The resistant.
Oh yes, they're absolutely. Drug resistant, multi-drug resistant is something that we do see, and even here we do see it in Alberta in South Zone. So every time that a sputum or any kind of culture is taken for tuberculosis, they actually do sensitivities on that, and that is mandatory. Jennifer, that's the TB lead, is also on the call from Red Deer if she wants to add anything, but we do TB, multi-drug resistant TB is still treated. The difference if that is the medications have to sometimes be second or third line treatment regimes because of the resistance, and the treatment duration is often longer than the general 6 to 24 months of direct observed therapy by an RN. And it's definitely from a worldwide standpoint, it is definitely a raising concern. Absolutely. And that's why TB medication is also very controlled. And that's why the medication is direct observed therapy by an RN, is to make sure that the medication is taken properly, just to avoid further problems with multi or drug resistant TB.
And is there any specific PPE that needs to be followed with the drug resistant versus the latent and the active TB?
Latent TB doesn't need any PPE protective mechanisms because it's not infectious. Active TB is, from an infectious standpoint, is treated the same as multi-drug resistant TB.
Thank you.
Tennille, I just wanted to add, with regards to the diagnosing of active TB, that's why you will always see sputum, always kind of recommended, because the gold standard is to grow the sample, because then they can do the drug susceptibilities and ensure that it's not drug resistant. So whether it's spontaneous sputum or induced sputum, or then even moving to a bronchoscopy, if you can get the sample, then we can always drug resist it and then treat it properly.
And interpretation, try and get your sputum sample observed if you can, because trying to teach somebody who speaks English how to do a sputum sample is hard enough. Trying to teach somebody who does not speak English how to do a sputum sample properly is very difficult.
Okay, great, thank you. And if there's any other thoughts about TB or sputum or anything like that, we'll hold them till the end. I'm going to invite Lindsay Schwab to talk a little bit about making referrals to chronic disease management.
Hi, it's Lindsay here. You guys can hear me? Just let me know if you can't. So I work at the Alberta Healthy Living Program, and of course, sometimes people who are new to our country have chronic diseases that they bring with them. So I work in diabetes, so that's where my experience mostly is, and I think that we've had referrals for other things to just see a dietitian, or potentially for some of our heart health programs as well. Our referrals usually come from family physicians or from the multidisciplinary clinic. So either myself or another nurse will be at multidisciplinary clinic, and we will usually offer a blood glucose screen and a blood pressure screen. And if we notice anything that's kind of concerning, we will make a referral to our own program. Our booking staff uses language line to book appointments, so it's worked really, really well for them. They really love to know the language that the person speaks on the referral. So if you're sending a referral to a different program, it's really helpful for that booking staff to know what is the language spoken, and including dialect if possible, because that can really help in getting an appropriate language line interpreter. However, our booking staff has become really creative, and they'll find all kinds of ways to try to figure out the language if they're just doing a cold call to somebody they don't know isn't an English speaker. Sometimes they'll book that appointment with a family member who speaks English well, but usually it's language line. So they just get language line on the phone, and then they make the third person call to the client. We do book our referrals here a little bit longer than they normally would be if English isn't their first language. So that allows our coaches time to call the language line before the person shows up, connect with that interpreter on the phone about what's going to be discussed in the visit, and maybe kind of sort out some of the cultural stuff if there's anything that we need to be aware of. We have had situations where people will bring their own interpreter. Often it's a family member, and we've actually had really good responses when we say, "Oh, I see you brought an interpreter. Are you okay if we also call the language line?" And often that person that's coming to interpret is like, "Yes, thank you." Like, they're very happy to not have the responsibility of medical interpretation. So it hasn't really ever been an issue that we've noticed to offer language line even if they bring their own interpreter. Like, I think some people kind of assume that the person might be offended if they're coming to interpret and then aren't needed, but I think they're often very relieved that they don't have to take that on. So we do a little longer first visit with that person who's not an English speaker, and then we get a bit creative in how we communicate after that, because often we'll do phone follow-up where we're reviewing blood sugars, but it's often much easier. Like, I'm thinking of women who have gestational diabetes. They need to review blood sugars with a dietitian or nurse every week, so they'll often just email a picture of their blood sugars, which they can usually take with their smartphone, and it works really slick, and then they can kind of communicate without having to go read out weeks of blood sugars over the phone. So just trying to be a little bit thinking out of the box about how we can make the service happen in a way that's easier for the person, or in a way that they maybe would be more comfortable accessing it. And I think that's about all I had to say about referral to chronic disease. Does anybody have any questions about how that works?
Great. Thanks, Lindsay.
Thank you.
We're going to move on to an overview of Interim Federal Health Program. Bojana will speak about that. We do have some resources on the slides that you can go directly to after the presentation, but I'll hand it over to you, Bojana.
All right. So I will just talk a little bit about Interim Federal Health Program. That you will usually hear us refer to as IFH, and even our clients who we serve usually refer to as IFH just using that short acronym. Resettled refugees who have been selected for resettlement to Canada are covered under Interim Federal Health Program, and they do receive short-term health coverage that it's funded by federal government of Canada. Usually, usually resettled refugees or privately sponsored refugees or government-assisted refugees, or certain other groups such as protected persons. IFH covers basic services such as hospital services, medical services, prescription drugs, and then some supplemental coverage such as urgent dental care, vision care, mental health services, ambulance, medical devices, and nursing visits. More details, what is covered, will be included in the resources with the links to the website where more information can be found. Also, some of the services will require pre-approvals, and that usually takes some time. Resettled refugees, they do receive IFH document upon arrival to Canada, and they do need to present it to the health providers, either to dentists or pharmacists or other provider that they're accessing. Provider needs to register with Medavie Blue Cross, who manages all approvals and billing, and they will verify that coverage is in the place. One of the things that we often find from the new providers is that we get a phone call where they're either not registered with IFH or they don't know how the system works, and they're asking our clients to pay for services. And one of the things with IFH, refugees cannot get reimbursed. So only health providers can be reimbursed for the services. For all inquiries, if you need to register with Medavie Blue Cross, then you would need to work directly with them. They do have electronic billing process and pre-approvals, so it's starting to be very easy system to navigate. And then for more information for the healthcare providers, I would encourage everybody to go on the website, cic.gc.ca, and even if you type search IFH program, then you will get all the resources for yourself.
Great, thanks, Bojana. I'm just showing on the resource page that we do have all the links there, so you can take a look for yourself. Our next presenters are Lindsay Schwab and Laura Branner, who are going to talk about specifics to interpretation and translation. Are there any questions before we move on to that about interim federal health?
This is Jennifer. Sorry, I have a question just with regards to how refugees are settled, and I mean settled as in what city. Do they get to choose what city? And if they don't, if they're assigned a city, is there a length of time that they have to stay in that city before they can move to say where they wanted to go? And third, sorry, with that, is there any then communication? Say if a person is settled in Lethbridge but has distant family in Toronto, they stay in Lethbridge for a maximum amount of time, and then they move to Toronto. Is there any communication by the federal government to note that the client has moved to Toronto, or is that up to the client to tell the federal government that they're moving to Toronto? How does that work?
So it's Bojana here again. So before resettling to Canada, refugees are either asked if they do have any family members, friends in Canada, and if they would like to be settled in cities where there are established relationships with other people. If they say yes, most of the time, they are, sent where the family and friends are. However, if they don't have family, friends, and then they're usually sent in one of the 33 cities outside of Quebec. So that is chosen overseas. Once when they come to Canada, they're free to move. So there is no particular, there is no restrictions on time. They can be 2-3 weeks in Lethbridge, and then they can move to any other destination in Canada. And then in terms of if they do have a family in Toronto, if they are on the resettlement assistance program, income support, they do need to notify government so that they are able to receive assistance in that next city. And that usually applies in the first 12 months. But if it's after 12 months, then you just need to change your basic information, health coverage, and all other things like everybody else will do. Does that answer your question?
Yes, it does. Thank you.
Yeah, and we connect them with the services, like with settlement services. If they're moving to Toronto, we initiate conversation and letting know our colleagues in Toronto that they're coming, and we would fill out some paperwork just that they have an idea what has been done here and what needs to be continued in Toronto in terms of settlement.
Thanks, Bojana. All right, and moving on to interpretation translation, Lindsay and Laura.
Hi, this is Laura. Can you hear me?
Yes, we can.
Yes.
Yeah. Okay. I'm cognizant of the time. We have 1 minute left, so I won't say too much. But I'm delighted to be the Lethbridge Local Immigration Partnership Coordinator, and I work out of Lethbridge Family Services, Immigrant Services, and we have IRCC funding, which is federal funding. I just want to make sure that you visit our website, which is Stasha has given the link to that, and I just want to bring your attention to something that's on the website, which is called Tips for Speaking with Someone That Is Learning English, and many of the things that have already been discussed today, but a few other things. So I really encourage you to look at the document, and I'm happy to answer any questions. If you go onto the website, there's a section where it says contact us. It's only me that reads those. So if there's any questions, I am happy to answer them. And the only other thing that I'll add is that we're continually working on the website. There's information for newcomers, service providers, employers, etc. And I encourage you to look at it from time to time because we're continually adding things. We're going to add some things about different cultures so that you can get highlights pretty quickly. We'll advertise things like this, the webinar that you're listening to. There'll be some others from other sections as well. That's I think that's it for me.
And Lindsay, anything to add?
I think we talked about a lot, just how to use language line and medical interpreters as we went through. I did want to point out that all the Chinook primary care clinics do have access to language line. They may need to check with the PCN to find out their language line ID and code though. So just a heads up, if you've got somebody at a clinic who's saying they don't have access and they're part of Chinook primary care, then the PCN, then they probably do have access. All AHS facilities have access to language line. Yeah, and it's a really great tool to ensure that we're actually getting real informed consent. So that's difficult to do with a child interpreting for a parent or, that kind of thing. So just, I'm probably speaking to the people who are using language line already, but it's a really great tool that we have available to us. So yeah, that's it for me.
All right, are there any further questions? If not, I'm going to hand it over to you, Bojana, to wrap things up. I'm just going to move the slide as soon as I'm using two screens.
Hi, my name is Barb Dorghetti. I'm a public health nurse in Red Deer, and I'm a lead for Immigrant Clinic here in Red Deer. And so I've been listening to you guys talk about your multidisciplinary clinics, and we're having huge issues with our clinics because we are truly immunization focused, but there's definitely gaps that we're noticing. And even CARE, which is our Central Alberta refugee effort, has been saying that clients are also wanting more. So Jolene, I was just wondering if you could kind of from a refugee view, walk me through your primary and secondary clinics. Like, how does it look in their aspect? What do you guys do? How do you assess them? That kind of thing. Just because I could see that there's potential here in Red Deer that we could work that way.
Right. So I'll talk about maybe what we're doing now as our regular practice versus what we did kind of in that initial sort of crisis time when we were seeing so many come in all at the same time. So like I said, we actually have, I have two staff who take turns being kind of the lead for the multidisciplinary clinics, and they work closely with Bojana and her staff from Lethbridge Family Services to get the information that we need so that we can have things all set up. And then we have moved to have them at our public health office here. So, and Tennille, maybe jump in, and Lindsay, jump in if I'm totally off base here. But they come with their interpreters, and they kind of rotate through. So we have oral health, like I said. Most times we get them to go through oral health first, just because they tend to be a little bit more scared of things, and that's one thing where they have to open their mouths, right? So we have them typically go through oral health first, and then they can either come through to public health to get their immunizations, and we have just a couple of our clinic rooms that are blocked for the multidisciplinary clinic that particular day. So then the families will come as units, right, to each of the sort of stations. So generally oral health first, and then depending on what the schedule is and how many families we have all coming into those first clinics, they could go through public health for the immunizations. They could go to Lindsay with the Alberta Healthy Living Program, smoking cessation if we have that. If anyone in the family is eligible for the Better Beginnings, then they meet up with that particular staff member as well. So it's all kind of housed right now in our public health office, which we've kind of made different rooms available on those particular days as they're scheduled. The secondary clinic, we typically run, so what we do is we have morning clinic as our primary clinic, and then the afternoon is a secondary clinic of the clients who were seen last month, if that makes sense. So we have a full day multidisciplinary clinic. Morning is first clinic for some, and then the afternoon is the second clinic for the ones that were seen the previous month. And then, so for the secondary clinic, typically oral health, unless there is some specific concern, oral health does not participate in the second clinic, because usually they've been seen and then they've been referred to dentists in the community and those sorts of things. So it's mainly for us to get those second immunizations done, but also, like Lindsay said, to connect with some of those other services where they may not have been as comfortable sort of talking in the first clinic. So that's kind of how we've set things up. And I definitely don't have any problem with going into detail, a bit more detail of how we came to do what we're doing a bit more offline, if that helps, just because there is quite a bit of the planning that happens ahead of time to get these things going where they are.
Yes, that'd be great.
Absolutely.
To connect with you, and I don't know if my manager would prefer to do that, or that I can do that connect directly. But yeah, I will ask Stasha to send me all your guys' contact, because I have this feeling I could really phone you up and ask you a bunch of different questions.
Absolutely.
You guys sound like you have such a good, smooth system running that you guys would be a great way that we could bridge our services and find out where we can move forward.
You bet. So Barb, whether it's you or your manager, whoever, we're totally happy to go through kind of what we've done and how we've come to where we are.
Okay, perfect. Thank you.
It's Bojana here from Lethbridge, and maybe I can give something from the settlement perspective. So one of the things in a Red Deer, you do have two agencies that are working with the refugees. So when it comes to the resettle of refugees, you might want to also involve Catholic social services, who do receive all government-sponsored refugees, and they're eventually referred to care, because I think that you need to work collaboratively with them, because I can hear lots of actually, medical needs that Red Deer is also identifying, and see what our needs are so that you can develop your own clinic based on what they see, but I know they're expressing a lots of health needs and issues, right?
Yes, we're close connected with LaSalle, so they are part of our working group. And this is, we're moving forward because we definitely need to upgrade what we have been doing because it's just not quite good enough.
One of the things what we do, and I'm not sure if we touched on public health, Jolene and her team, they developed a assessment tool, and they would actually, write down all the health needs, dental health needs, mental health needs, and any other referrals that are also required. And then we would communicate what those needs to be done. And then my practitioners take copies of those assessment tools, and then they make sure, okay, so that needs to be addressed. We need to go to dentist, or we need to make an appointment with Children's Allied Health and those services. So it's kind of coordinated effort who does what. And we found actually that care for our clients, it's much better. We don't have that falling through the cracks, gaps. So that's something that it really worked well for us in the last 3 years.
Thank you.
Just conscious of the time, any last questions for any of our presenters? Okay, over to you, Bojana, to finish up.
Okay, well, thank you all for attending, and I would like to thank our presenters and committee members of Newcomers Health Advisory Group to make time out of their busy day and come and provide us some of the historical information and what has been done in Lethbridge. So we do have organized our next webinar, which is June 6th from 12 to 1:30 p.m. The topic will be low German-speaking Mennonites in Southern Alberta. And our presenter will be Tina Fielding, Community Health Representative and Low German Mennonite interpreter. And following the webinar, you will be receiving survey. Is that right, Sasha?
Yes.
So your feedback would be beneficial to us because we're really looking forward for this to become regular occurrence on a quarterly basis for the health providers. Thank you all, and I think over to you, Sasha.
All right, you will get an email from me with a link to SurveyMonkey, everybody's favorite, of course. And really thank you all. Spread the word. If there's anything that we need to improve, please let us know. Thanks again to our speakers, and hope to talk to you again June 6th. Thanks, everyone.
Thank you.
Thanks, Dasha.
Thanks.